Well, I'm Dodie Brown, and I am privileged to be here to talk about a favorite topic. Because I kind of grew up in community health nursing at the beginning when home health was just getting started in South Dakota. The major impact on home health was Medicare legislation, which was passed in 1965. And in South Dakota, the South Dakota Department of Health, through the Community Health Nursing Division, established a statewide program through community health nursing. At that time, Pennington County Health Department was a pilot study for starting up our own home health agency as a sort of a pilot agency. And that happened in 1968 when I joined the department as a community health nurse. So we were covering home health visits and learning all about home health coverage during that time. We continued that until about 1972. At that point, I became the supervisor for community health nursing in Pennington County. And I could see that the program was not going to grow when you had nurses so stretched out, doing so many program of projects, that we needed a dedicated staff. So I started hiring separate additional staff through the home health agency. So that continued till about 1982, when the actual I think interest in expanding home health to include more coverage for terminally ill patients became a real focus from the nursing staff. We started just studying more about how we could implement that and bringing our mission message to the county commissioners, who actually were part of the home health sponsorship. At the same time, Regional Hospital was interested in becoming more than acute care. So they wanted to develop community health services. And after about a year of negotiations and discussion about what our vision was and what their vision was, we came together and we actually transferred the program to the hospital in January of 1983. It became a department of Regional Hospital. One of my first jobs was just kind of seeking out some reimbursement to get the staff fully educated about hospice care. So I wrote a grant by the seat of my pants through the Bush Foundation, and I think we were kind of a unique request. They said, we really don't want to give you money for operations. And so I assured them that, because they thought we'd become dependent upon that and wouldn't be able to sustain our program. And I said, well, I can assure you that we won't use it for operation. We will use it for education, and both in the community and for our staff. National Hospice Organization and the few programs that were existing in the United States, which were pretty much volunteer-based, were pushing for Medicare hospice legislation. And that was passed in about November of 1983. So I went to a conference with one of the administrators at the hospital to learn about what the reimbursement issues were, how to become Medicare certified, what were the standards of care that we would need to accomplish. It was important for us to have that certification because it provided a solid base of reimbursement for patients. Out of that, we could easily share the many specific benefits of the hospice reimbursement, which was providing for all the visits, providing for the equipment, for the pharmacy, and whatever the patient needed, it was paid for on a per-day basis. It had 4 levels of care, which included routine home care, residential care, and inpatient care. And we also had some respite care provision within that Medicare benefit. So the push came for us to develop a hospice inpatient facility. And actually, I fought for that pretty vigorously for years before I could convince the powers to be that it was doable. And I felt good that when I left the program to Marcia Taylor, that she was inheriting a comprehensive home care department. I was with the program from the beginning and retired when I was 65 at in July of '08, and so this has been sort of my legacy